Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will present a new subject on pediatric surgery made easy, which is intestinal atresia and stenosis. This subject is very important to all pediatric surgeons. Let's start. Today's subject, intestinal atresia and stenosis. Content will be duodenal atresia and stenosis, jejunal-ileal atresia and stenosis, colonic atresia, and finally, how to approach a neonate with bowel obstruction with a simplified algorithm may be useful for all pediatric surgeons. Number one, what is intestinal atresia? Intestinal atresia means congenital absence of the bowel lumen, which result in obstruction. If this obstruction is not corrected, it may cause death from loss of gastrointestinal fluids, pulmonary aspirations, or malnutrition. What is the etiology or the suspected etiology for the intestinal atresia? May be related to intrauterine ischemic event causing necrosis with resorption of the involved bowel segment, or may be related to what's called failure of recanalization. All of us know that all tubular structures of the GIT pass in a stage of what's called embryonic solid stage or cord stage. Then this stage followed by canalization. If there is failure of this canalization, we can call it failure of recanalization and may lead to the development of intestinal atresia. The first one, the important, is duodenal atresia and stenosis. Duodenal atresia is the frequent cause of the neonatal intestinal obstructions, about 1 per 5,000 to 10,000 live births. The boys more affected than girls. The associated anomalies may reach about 50% of these neonates. What are the suspected etiology for the duodenal atresia? The first theory is a failure of recanalization, or what's called persistence of the embryonic solid cord stage. As we said that all tubular structures pass into stage of the solid cord stage. There is a hyperplasia of the epithelial lining with complete occlusion of the lumen, followed by recanalization. If there is failure of this recanalization, the duodenal atresia may develop. So it is not impossible to say that physiological atresia persists and develops into the congenital atresia. However, there is some objection about this recanalization theory, as it is not explain the different varieties of the duodenal obstruction, not explain the presence of the membrane, not explain the one-sock deformity. There is some objections about these theories to explain the etiology of duodenal atresia. Second etiology, or second hypothesis, or second theory may be related to genetic etiology. This genetic etiology evidenced by the association of the duodenal atresia with a Down syndrome. About 1/3 of neonates have a Down syndrome. Also may be interruptions of the fibroblast growth factor 10 gene result in duodenal atresia, evidenced by trial on the mice embryo. Interruption of these factors produce duodenal atresia in about 30 to 50% of mice embryo. Also, the third hypothesis may be related to familial conditions. However, duodenal atresia usually not regarded as a familial conditions. However, there is a several report of familial cases. Some cases reported annular pancreas with duodenal atresia related to microduplications on chromosome 6q24. Sometimes it may be a part of the hereditary multiple intestinal atresia. In such cases, this infant has a fatal outcome even with bowel resection and correction. May be related to specific mutations. These specific mutations described in the literatures maybe microdilation, maybe mutations for some genes involved in the pancreatic development, maybe mutations in the FOXF1 gene. So it is likely that mutations in many genes may be associated with duodenal atresia and no specific mutation for certain gene. What is the pathophysiology of the duodenal obstruction? Duodenal obstruction may be intrinsic or extrinsic obstruction. Intrinsic obstructive anatomy may be related to atresia or stenosis. Extrinsic obstructions may be band of midgut malrotation or midgut volvulus, may be related to the presence of the annular pancreas or the preduodenal portal vein. Annular pancreas means that the pancreas is occluding the second part of the duodenum, compressing or obstructing the second part of the duodenum. Actually, also some authors consider this, the presence of the annular pancreas is not the cause for the duodenal atresia, but it is associated with duodenal abnormalities. So that the pathology starts at first in the duodenum itself, duodenum not formed. So the pancreas present in these pictures, not caused by the normal developed pancreas and the annular pancreas compressing the second part of the duodenum. This is debate still present about whether annular pancreas is associated with duodenal abnormalities and already present duodenal atresia, or to be the cause of the obstructions of the duodenum, of normal duodenum. So the associated congenital anomalies may be the Down syndrome. Malrotation is very common. Congenital cardiac abnormalities and maybe the major cause of morbidity or maybe mortality in these infants. Annular pancreas, also genitourinary and anorectal malformations. The classification of the duodenal obstructions may be classified as a stenosis or atresia. We mean by stenosis incomplete obstruction of the lumen by the fenestrated web or external compression by the lead band or annular pancreas or preduodenal portal vein or duodenal duplication. This is called stenosis, incomplete obstruction. On the other hand, atresia. We have type 1 atresia, more than 90% of cases, related to the presence of luminal diaphragm. There is obstructions inside. This is a duodenum opened and there is a diaphragm or membrane. Mucosal and submucosal, the duodenum remain in continuity. So the continuity of the duodenum is continued. This diaphragm or membrane may have what's called windsock deformity. Windsock means that the origin of the diaphragm not related to the obstruction. So the diaphragm is present and balloned distally. So its origin will be high up than the dilatation of the duodenum. The second type is called type 2 atresia, which include dilated proximal duodenal part and collapsed distal part. Both segments are connected with a fibrous cord. So this is the type 2. Type 3 means that the dilated and the collapsed separated by gap. No fibrous cord connecting both segments. Now, how to diagnose duodenal obstruction? Usually diagnosis by the prenatal screening by ultrasound is universally and widely used in all over the world. There will be mother polyhydramnios. Number 2, double bubble sign. This is a double bubble intrauterine ultrasound. This is the stomach, a pylorus, and the duodenum. Double bubble means presence of the gas and the fluid in two structures, the stomach and the duodenum. However, duodenal obstructions occur about around the 12 weeks of intrauterine life. Ultrasound diagnose the duodenal obstructions at the 7th to 8 months of gestation. May be explained by that there is immature gastric emptying, failed to dilate the duodenum until later gestation. So the obstructions occur early. However, ultrasound diagnosed it very late in gestation as there is very low gastric pressure. So these gastric pressures take a time to dilate the proximal duodenum and produce the usual double bubble sign. The postnatal presentation. when the neonate or the infant born, there will be bilious vomiting. Bilious vomiting means vomiting containing bile, bilious vomiting. However, non-bilious vomiting reported in about 15% of cases if the obstructions of the duodenal obstructions is preambulary, proximal to the ampulla of water, so the obstructions before the entrance of the bile duct. Number two, there will be scaphoid abdomen, no abdominal distension, as it is a type of the proximal obstructions. However, full stomach may be palpated in the epigastric region. Significant gastric aspirate will be more than 20 milli. Normally, this aspirate is less than 5 milli. Duodenal stenosis, however, carry a diagnostic dilemma and unclear diagnosis until the enteral feeds start and there will be feeding intolerance, emesis, and the gastric distension. So bilious vomiting, scaphoid abdomen with significant gastric aspirate, this is usually the postnatal presentation. The most important, or the third item, is the radiological diagnosis. Plain abdominal X-ray, usually sufficient to confirm the diagnosis. There will be double bubble sign. This is called double bubble sign. This is the first bubble related to the stomach, the second bubble related to the duodenum with no distal gas. The distal abdomen is gasless. So this is diagnostic with no distal gas. And if there is no double bubble, we can induce the double bubble by injecting about 40 to 60 milli of air inside the nasogastric tube. So you will reproduce the double bubble if the double bubble is missing, or if the child already, some doctors insert nasogastric tube and suck or aspirate the air from the stomach and the duodenum. So you can reproduce this double bubble. The second X-ray is for what's called duodenal stenosis. Also, you will see the double bubble sign, however, with scanty or faint distal gas. Very important differentiation, as the second X-ray with duodenal stenosis may be dangerous sign. This baby may have malrotation with significant midgut volvulus. So usually, in the classic double bubble sign, there is no distal gas. In duodenal stenosis, or maybe some other exceptions, there is maybe distal gas. So the presence of the distal gas may be related to the partial obstructions by the stenosis or perforate web or lead band. This is lead band, abnormal band connecting the intestine to the lateral abdominal wall, crossing all over the duodenum, causing obstruction. This is one form of the external compression or external obstruction of the duodenum. Or maybe what's called very rarely bifid common bile duct, air bypass atresia. The orientation that the bile duct, one part or one limb of it open in the proximal obstructed duodenum and the second open in the distal obstructed duodenum. So the air can bypass the obstruction. So this is the explanation for the presence of the distal gas with the double bubble sign. May be related to partial obstructions, presence of the perforated web, or external pressure by lead band, may be very rarely related to the bile duct abnormalities, bifid common bile duct. The contrast study is very essential for diagnosis to exclude the malrotation and the midgut volvulus. There will be spiral configurations of the duodenum. There will be spiral configuration like corkscrew appearance of the duodenum and the upper jejunum. Very important, any bilious vomiting with decompressed stomach on a plain film or double bubble with distal gas to perform upper contrast study to exclude catastrophic midgut volvulus. So upper contrast study will be indicated in more cases of the duodenal obstructions with tiny or faint distal gas or in the presence of the partial obstruction. What is the preoperative management? This baby will need an operative corrections for the duodenal atresia and obstructions. Preoperatively, you must resuscitate the baby well, perform gastric decompression, avoid hypothermia and hypoglycemia. Also, there will be a need for fluid and electrolyte replacement, as vomiting may lead to dehydration hypokalemic, hypochloremic alkalosis. Also, we may need to perform echo to exclude high rate of associated cardiac abnormalities. What are the basic operative principles? The basic steps will be related, number one, to what infant temperature control. Almost all infant with a duodenal atresia will be premature, low birth weight infant. This infant more liable to hypothermia, and there is maybe major morbidity and mortality related to hypothermia. So infant temperature control is very essential. Number two, what's your incision? Choose your incisions, whether open or laparoscopic. Number three, exploration and identification of the pathology. Number four, we need to define and identify the type of the atresia. Number five, management of massively dilated proximal duodenum. Infant temperature control, usually by using the overhead warming lights, warming blanket, and dry drapes. The drapes over and under the baby are not allowed to become soaked during preparations, abdominal preparations with iodine or betadine before surgical incision. So please, you must be sure that the drapes are dry to avoid loss and evaporations of the temperatures and hypothermia. Incision, you can choose between open approach or laparoscopy. In open approach, we have two incisions, the traditional transverse supraumbilical incisions and the circumumbilical incisions or minimally invasive incision. Exploration and identification of the pathology. Once you incise the skin and the muscles and enter the abdominal cavity, the first item you must look for it is the malrotation, presence or absence of malrotation and mid-gut volvulus. If the colon is already in a normal position, malrotation may be not coexisting. The duodenum adequately mobilized by Kocher's maneuver, and also it is important not to dissect or manipulate the duodenum medially to avoid injury to the ampulla of water or the common bile duct. The fourth item is to define the type of atresia, type 1, type 2, type 3. The most important is type 1. If you find continuity of the wall of the duodenal wall is continued and obstructed from inside. In such a case, and at this point specifically, you must expect and look for the Wensock web or Wensock diaphragm. We say that Wensock means that this is a diaphragm. However, this diaphragm not present at its origin only. It balloned distally. Balloned means that part of the dilated duodenum is below the origin of the diaphragm, is below the actual obstruction. So we say that balloned and dilated proximal duodenum is usually above the obstruction. The part above the obstruction is dilated, the part below the obstruction or below the atresia is collapsed. In cases of Wensock web, the dilated duodenum may be below the obstruction, so the anastomosis may be formed in error. So the surgeon must be very alert to, number one, palpate or look for the apparent annular origins of the diaphragm. If there is not apparent or the palpation not feel this diaphragm, you can insert nasogastric tube. This nasogastric tube will stretch the diaphragm and making its origin well marked on the duodenal. In such cases, you will perform longitudinal incisions over this origin, which is called longitudinal duodenotomy. This is longitudinal duodenotomy over the origin of the membrane. And then you start your dissections. Usually avoid the ampulla of water damage because it opened in the medial part of the web or posteriorly close to it. In type 2 and 3, you will find mural discontinuity. Means that part above and part below, whether connecting by fibrous cord, this is type 2. Not connecting and there is a gap, this is type 3. So the difficulty with type 1. In type 1, if you find duodenal continuous and obstruction from inside, expect and suspect and identify what's called Wensock web, balloned distally. So the anastomosis may be performed in error between an obstructed and obstructed part. In type 2 and 3, this is called mural discontinuity. The usually performed duodenostomy is a diamond shaped. Diamond shaped, which means that you perform transverse incision at the dilated proximal segment with equal lengths, longitudinal incisions on the collapsed distal segment. Then you will anastomose the angles to the above transverse incision to the midpoint of the longitudinal incision, and this anastomosis will be like diamond shape, will be kept open all over the time, which is very important. Some authors described side-to-side duodenostomy, not to perform this diamond shape. However, you will perform a transverse parallel incision in the proximal dilated duodenum and anastomose to the same parallel incision of the distal dilated duodenum. So this is called side-to-side duodenostomy. However, diamond-shaped duodenostomy allow earlier feeding, earlier discharge, good long-term results. Side-to-side duodenostomy, although it's effective in relieving the obstruction, associated with high incidence of anastomotic dysfunction and prolonged obstruction. So most surgeons prefer diamond-shaped duodenostomy. What to do with massively dilated proximal duodenum? What's massively dilated? Prolonged obstructions will lead to hugely dilatation of the proximal duodenum. So these proximal dilatations will promote stasis with bacterial overgrowth with impaired peristalsis. So we have what's called tapering duodenoplasty. Tapering duodenoplasty means fold of the anti-mesenteric. This is anti-mesenteric, the side without the mesentery, strip or fold of the anti-mesenteric wall resected along the longitudinal axis of the dilatation after insertions of appropriate catheter inside the duodenum, not to make a duodenal stenosis. So it is called tapering duodenoplasty. Maybe performed with a linear stapler and maybe performed manually with manual suture. The nasojejunal trans-anastomotic feeding tube is very important. Very important to pass a feeding tube through your anastomosis to allow early post-operative feeding and reduce the need for the TBN with its complications. In premature infant, some surgeons insert the tube via the gastrostomy, stem gastrostomy, perform gastrostomy and insert the tube. Tip of the tube should be go well down to avoid its displacement. So it's very important to put in your mind that nasojejunal trans-anastomotic tube is very important. Other bypass technique that may be utilized, this is called the gastrojejunostomy. Leave the duodenal obstructions as it is and anastomose the stomach to the loop of the jejunum. However, as we see in this picture, suppose that the duodenal obstruction here, the anastomosis is performed between the stomach and the loop of the jejunum to bypass the obstruction. However, associated with high incidence of marginal ulceration, because the stomach contains high HCl, so this HCl will perform ulcer with the jejunal mucosa, which is not accustomed to this HCl or the presence of HCl. Or duodenojejunostomy associated with high incidence of the blind loop syndrome. You anastomose the duodenum itself to the loop of the jejunum, and you will have a closed loop obstructed proximal and loop and obstructed distal. So the preferred technique is to perform diamond-shaped duodenostomy. Regarding laparoscopic approach, the principles is that the baby placed supine. There is a 5 millimeter umbilical trochers for insufflations. We used 2 instruments, one at the right lower quadrant and the others at the left upper quadrant, and the fourth is the liver retractors. We may use traditional liver retractors or take a suture from inside the abdomen around the falciform ligament and tie it outside. The duodenum coherized as usual and localized the obstruction, identify the type of the atresia. Same principles for the standard diamond-shaped duodenostomy is created. The distal bowel examined to ensure that there is no obvious secondary atresia. we inject saline and inspect the distal bowel to suspect that there is no associated atresia. However, some authors claim that there is no need for such research because the duodenal obstructions is a type of failure of recanalization and usually jejunal-ileal atresia related to vascular insult late gestation. The post-operative care for the neonates with duodenal atresia will be also to maintain the temperature control, intravenous infusion of dextrose saline, electrolyte management. If there is prolonged bile stent aspirate because inability of the markedly dilated duodenum to produce effective peristalsis, this may happen and it will be improved over the post-operative follow-up. Transanastomotic feeding tube, very important to start feeding in the about 24 to 48 hours post-operatively. Start of oral feeding. There is a certain debate or some debate about this. Previously, most surgeons wait for the gastric aspirate to become less bilious and the volume of the gastric drainage to decrease, meaning that there is a return of intestinal function. However, recently, many authors and many surgeons found that this waiting is not necessary. As in laparoscopic duodenal anastomosis or laparoscopic duodenal atresia, the feeding starts without this adverse effect on the 5th post-operative day after upper contrast study relieving that there is no leak. So these times consumed in waiting until the gastric output become less bilious and the volume decreased may seem to be less reasonable in the sync of the era of laparoscopic duodenectomy. Postoperative mortality for the duodenal atresia repair reported to be very low, about 3 to 5%, and the majority of the deaths related to the complications of associated cardiac abnormalities, prematurity, and the low birth weight. The long-term complications may be related to delayed gastric emptying, severe gastroesophageal reflux, bleeding peptic ulcer, megaduodenum, duodenal gastric reflux, and gastritis, blind loop syndrome, intestinal obstruction related to adhesions. This is on the long run, the neonate may develop each of these complications or may not. The most important is the development of persistent megaduodenum. As we says that megaduodenum is the dilatation and dysfunctions of the first part of the duodenum above the obstructions with absence of the effective peristalsis. We perform what is called tapering duodenoplasty. Tapering duodenoplasty, we perform or remove a fold of the anti-mesenteric part of the duodenum after inserting adequate caliber tube. This will be lead to treatment of this megaduodenum. The stress here on the importance of performing this tapering duodenoplasty at the initial surgery to avoid the development of persistent megaduodenum and its complication. So in the primary surgery or initial surgery, if you face dilated duodenum, megaduodenum in the first part, this megaduodenum or dilated duodenum, you must consider to perform tapering duodenoplasty at the primary operation to improve the immediate post-operative GI function, prevent the later development of megaduodenum. Now we will shift to the second atresia, jejunal-ileal atresia and stenosis. After the duodenum, anatomically we have the jejunum and ileum. Both may be affected by atresia or stenosis like the duodenum. Also, it is a common cause of neonatal intestinal obstructions. About a third of the infant also premature and small for age. The incidence reported about 1 in 5,000 live births. No clear etiology. However, maternal use of vasoconstrictor medications may be incriminated. Also, cigarette smoking during the first trimester may increase the risk. The etiology is supposed to be related to vascular or ischemic insult affecting a segment of the bowel, and this segment drop or reabsorbed, leaving the both ends obstructed and blind, proximal and distal end. The vascular disruption theory is confirmed, experimental. Some authors ligating the mesenteric vessels in the fetal duct and resulting in atretic lesions of the small intestine. Also clinical evidence by the presence of the bile and the hair or some epithelial cells distal to the atresia. So they suppose that this lumen was patent, allowing swallowing of the amniotic fluid with passing of this content, followed by ischemic insult or ischemic disruptions or vascular insufficiency and the development of atresia. What are the classifications? Jejunal-ileal atresia classified into 5 types, from type 1 and type 3A, like duodenal obstructions. Type 1, bowel wall continuity. Type 2, separations with a presence of the fibrous cord. Type 3, there is a gap. This is the same from type 1 to type 3A. Multiple atresia may be reported up to 30% of the neonates. In stenosis, there is a will be short, rigid, localized narrowing of the intestinal lumen, no disruptions in the wall, normal intestinal length. In type 1 atresia, as we see, there is a transluminal membrane, dilated proximal and collapsed part. This is dilated proximal and the collapsed part, and this is the membrane inside. There is a membrane with proximal lumen here and distal lumen here, and there is a certain membrane inside, bowel usually of normal length. This is type 1. In type 2, blind end, there is the fibrous cord separation, like duodenal atresia. Proximal, distal with fibrous cord connecting both. In type 3 atresia, there is a gap separating the proximal dilated part with distal with no fibrous cord, and there is what is called V-shaped mesenteric defect. This is V-shaped mesenteric defect. Dilated proximal, distal atretic with V-shaped mesenteric defect. The bowel length equal the length of this defect. The bowel length defect equal the length of this defect. In type 3B, or what's called apple peel or Christmas tree atresia. In this type, there is abnormalities of the superior mesenteric artery. So there will be proximal jejunal atresia with agenesis of the mesentery, and the remaining intestine will form a helical or apple peel around a single perfusing artery and vein. There is a large mesenteric defect, and there is short bowel. So the distal bowel will course as corkscrew around single collateral vessels, provide the blood supply by the retrograde flow, maybe from the remnant of the ileocolic or right colic branches. Infant often premature, and about 50% may have a malmutation. This is difficult types of jejunal-ileal atresia. She is called apple peel or Christmas tree atresia. Most likely may be related to superior mesenteric artery occlusions intrauterine, extensive infarctions of the segment of the intestine, failure of the superior mesenteric artery development theory. However, maybe some authors says that this is not true, because meconium presence distal to the atresia indicate that the atresia develops after the bile secretion around the 12th week. And the superior mesenteric artery usually develops earlier than the 12th week. So if the cause of this type of atresia related to the superior mesenteric artery occlusion, there will be no meconium distal to the atresia. This is some hypothesis and its objections and what is with and what is against. The type 4 atresia, there will be multiple segment atresia. Multiple segment atresia, as you see, multiple one atretic segment followed by another atretic segment, third atretic segment. This is one atresia followed by one atresia with a proximal dilated. Majority of these cases are sporadic, no familial cases of intestinal abnormalities, most likely may be explained by multiple vascular insult to the mesentery with resorption of the affected segment, or intrauterine inflammatory process, or GIT malformation. Or maybe some authors claim that it is emboli from non-viable fetus to living monochorionic twin through placental vascular connection. There is a twin pregnancy of twin, and there is one died and one living. So there may be some emboli from the died infant pass through the placenta to the live one and making multiple intestinal atresia or type 4 atresia. All of these are theories and expectations to explain what already present. Also, there is maybe some form of atresia called non-familial multiple intestinal atresia, associated with central nervous system abnormalities, associated with severe immune deficiency, and some genetic mutations. Familial multiple intestinal atresia, this is autosomal recessive, involves the stomach and the duodenum, both small and large intestine, associated with prematurity and short bowel, and uniformly fatal, with type 2 atresia predominant. This familial multiple intestinal atresia runs in families transmitted by autosomal recessive mode of transmission. What is the pathophysiology? The pathophysiology is related to the proximal bowel obstruction with increased pressure from the fetal ingestion of the amniotic fluid, so may lead to cyanotic appearance with some areas of necrosis. Also, this dilated part will have a reduced or ineffective peristalsis. The distal bowel will be disused, narrow, with normal peristaltic function. At the level of the atresia itself, there is the ganglia of the enteric nervous system is atrophic, with minimal acetylcholinesterase activity secondary to local ischemia. So it is postulated that the intestine is not ischemic at birth. Some theory says that not ischemic, however, after birth, becoming so ischemic with the swallowing of air with massive distension. So this pathophysiology tried to explain what is present. We found that the proximal intestine is dilated, inactive, low peristalsis, maybe cyanotic, maybe some areas of perforation. So they explain that because of the swallowing of the amniotic fluid, or some other authors claim that this occurs after birth from swallowing of air. So maybe related to swallowing of the amniotic fluid intrauterine makes this huge dilatation and the ischemia and perforation, hypomotility and aperistaltic part, or maybe related to the swallowing of the air. Also, at the level of the atresia itself, there is a loss of the ganglia of the enteric nervous system with minimal acetylcholinesterase activity. This point will be important in the surgical management. So the implication of this will come in the surgical management. So all pediatric surgeons, you must resect this dilated bulbous part, because you know in the pathophysiology that is this not functioning well. So you must resect it and not performing an anastomosis to this dilated aperistaltic or not functioning well part. How to diagnose? As with duodenal atresia, we have a prenatal diagnostic ultrasound, which is usually used as a screening method, reliable in the later gestation. Why? Because the vascular insult usually occurs later in the fetal life. So if you perform an early ultrasound, you will not find anything. So this is reliable in the later gestation. You will find polyhydramnios. Any GIT obstruction will produce polyhydramnios up to 38%. Dilated proximal thickened bowel with increased peristalsis and distal decompressed bowel. Dilated, you will see the already present pathology. Clinically, also this baby, where we have bilious emesis, abdominal distension, failure to pass meconium. However, there is maybe gray plaques of mucus passing instead of meconium. The passage of the meconium, however, doesn't exclude the presence of the atresia, as the meconium distal to the atresia may be present in late onset lesion, as this vascular insult occurred later in pregnancy. So the meconium may be already present in the distal part of the intestine. Then atresia happened. So the distal meconium will pass after delivery. So this may be misleading. The baby pass meconium. However, this baby have an atresia, intestinal atresia. The fifth clinical presentation, high gastric aspirate. All infant with high gastric aspirate, you must suspect problem in the continuity of the intestine. Visible peristalsis after aspiration of the gastric content to overcome the atretic or obstructed part, maybe bleeding the rectum related to if the distal bowel is ischemic, especially in type 3B, may be related to presence of the blood in the stool related, or blood in the meconium related to the presence of ischemia. Abdominal tenderness or distensions or peritonitis indicate complications, perforations or volvulus of the bulbous blind ending bowel. So the neonate or the newborn may present with all of these clinical presentation or one or more of it. However, on the other hand, the intestinal stenosis will create a diagnostic difficulty. With intermittent partial obstruction or malabsorption, investigation initially can be normal. However, these babies may develop failure to thrive or progress to complete obstructions and require exploration. The radiological diagnosis, as we see, we start with a plain X-ray with the swallowed air as a contrast. We will find what's called triple bubble sign. There will be dilated stomach, dilated duodenum, and dilated jejunal. In the classic cases, you will see these pictures in the proximal obstruction. If there is proximal jejunal atresia, few gas filled and fluid filled loops of the small bowel with no further distal gas. This is the classic proximal obstruction. However, in the distal atresia, you will find a greater number of the dilated air fluid level reaching down, filling all over the abdomen. And in the neonate, it's very difficult. And we can say that it is impossible to differentiate between the small intestine and the colon obstruction in this infant. So there is a massively dilated loops of the intestine throughout the abdomen in the distal obstruction. In the proximal obstruction may be related to the presence of 3 obstructing dilated loops. The contrast enema will be very helpful. We'll find unused microcolon, and there is failure of the contrast material to reach the dilated proximal bowel. You see this black air, this is a dilated proximal bowel. The contrast material stop here cannot advance through the obstructed dilated bowel. Also, position of the cecum may be helpful to exclude malrotation. However, this is not a reliable sign. So this is microcolon, failure of the contrast to reach the dilated proximal bowel. Confirm the diagnosis that you have an ileal atresia, if there is a reflux of the dilated, of the contrast to the dilated or to the obstructed ileum may be related to the presence of meconium ileus. We will go to the differential diagnosis and discuss it. What are the differential diagnoses of jejunal-ileal atresia? Number 1, malrotation and mid-gut volvulus. With proximal jejunal atresia, malrotation may present with the same picture. Scaphoid abdomen or minimally dilated, present of X-ray with few gas-filled and fluid-filled upper loops, maybe meconium ileus. Meconium ileus cause distal ileal obstruction. So you may have in the X-ray multiple dilated loops. However, with meconium, the meconium will prevent the development of air fluid levels. So you will find the dilated loops without air fluid level. We discussed it previously in the lectures regarding meconium ileus. Also, when you perform a contrast enema, if the contrast can reflux into the terminal ileum, it will mix with the meconium, and you will see the meconium pellets inside the terminal ileum. Also, colonic atresia, as we said, that it is impossible in the neonate to differentiate between the dilated. This is small bowel or large bowel, especially in the neonate and the newborn. Hirschsprung and small left colon syndrome, or ileus due to sepsis or birth syndrome. So in malrotation and volvulus, we said that may be difficult to differentiate the proximal jejunal obstructions, few gas filled from the small bowel with no distal gas. So the upper contrast is mandatory in such cases to rule out and exclude catastrophic mid-gut volvulus. Meconium ileus, in such cases, the rectal examination will show meconium or just mucus presence, and also the contrast enema will show microcolon, and with multiple filling defect if meconium present in this microcolon, and if the contrast material refluxing into the distended impacted distal ileum, you will observe the pellets of the meconium. In atresia associated with cystic fibrosis, you will few air fluid levels with typical ground glass appearance may be visible. About 10% of baby with jejunal-ileal atresia present of meconium peritonitis. There is perforation occur proximal to the obstructions. Radiological appearance also of the meconium pseudocyst containing large air fluid level related to the late onset intrauterine bowel perforation. Moreover, intraluminal calcification of the meconium or intraluminal calcifications reported with intestinal stenosis or atresia. Meconium calcification in patients with hereditary familial intestinal atresia produce what's called string of pearls. In the colonic atresia, as we said, that rostral marking rarely seen in the neonates, so it is very difficult to differentiate the small intestine from the colon in neonates and the newborn. In ileal atresia, the contrast will show the microcolon, no refluxing into the dilated bowel. In colonic atresia, there is a microcolon with sudden stop or sudden abrupt of the contrast at the site of the obstructing colon. At this site, the dye will stop, indicating the site of the atresia. Hirschsprung disease may be related, also give the same presentation of dilated multiple loops filling the abdomen. However, the contrast enema in Hirschsprung may demonstrate finding very suggestive and may need confirmatory test with rectal biopsy. All this differential diagnosis will be discussed soon with how to approach neonate with bowel obstruction. In jejunal-ileal stenosis, the clinical and radiological pictures is determined by the level of the degree of the stenosis, and the diagnosis may be developed. Morphological and functional change in the proximal obstructed intestine depends on the degree of the obstruction. Limited study, contrast study may be useful to diagnose this jejunal-ileal stenosis. So what is the management? How to treat neonate or newborn with jejunal-ileal atresia? Usually the delay in the diagnosis can lead to impairment of intestinal viability, necrosis and perforation, fluid and electrolyte abnormalities, and sepsis. So you must diagnose and treat your baby or newborn or infant at a proper time. The preoperative management will include gastric decompression, fluid and electrolyte balance, antibiotics if there is suspicion for perforations or infection. Very important. The operative approach may be laparoscopic and open approach. Regarding the laparoscopic approach, it can be difficult. You understand that you have a newborn or infant with multiple dilated loops. So there is no space for pneumoperitoneum. So there is no space, markedly dilated intestine with small working space. So laparoscopic approach in such cases may be difficult. Maybe the alternative to perform minimally invasive circumumbilical incision and deliver all the intestine through the umbilicus and perform the same laparoscopic procedure or the same principles with more and advanced cosmetic results. Or maybe use open approach, open transverse abdominal incision. What are the basic operative principles? Like the basic operative for duodenal atresia, we need to know the basic principles for jejunal-ileal atresia. Number one, when you operate a case with jejunal-ileal atresia, number one, after incision, you must carefully inspect the entire bowel to see if there is perforations, cyanotic part, if there is second atresia. Number two, malrotation and volvulus. It is critical to identify malrotation of the and volvulus and identify and correct. Look for the position of the colon and the position of the DJ, position of the cecum and the appendix, very important. Isolate the site of any perforation to avoid contamination. If you find perforated part of the intestine, make a complete isolation to avoid contamination of the peritoneal cavity. Define the site and the type of the obstructions, how the junction between the dilated proximal and the collapsed part. This is the site of the obstruction. Number five, exclude second distal atresia. How to exclude? By cannulating the distal collapsed intestine and injecting worm saline. This worm saline will flow through the distal intestine, and you can observe if there is second atresia, the saline will stop at second distal atresia, because missing distal atresia may make a problem related to anastomotic disruptions. Pure anastomosis may lead to increased morbidity in this infant or newborn. Also very important to measure the length of the functional bowel. You must measure the length along the anti-mesenteric border and document the length. We have 100 centimeter length of bowel available in this baby. Document in the operative report. Primary anastomosis is the idea to perform a primary anastomosis with one layer 5O or 6O sutures, and testing this anastomosis for leak. Reinforcing sutures may be taken if needed or as the surgeon preference. The primary anastomosis is contraindicated in the presence of the peritonitis or neglected volvulus or the type 3, at some cases of type 3 atresia, type 3b atresia. So externalizations of the both end or performing stoma may be needed in limited number of cases. However, the general rule is a primary anastomosis. The mesenteric defect must be repaired with care to avoid rotating or kinking the anastomosis or injury the blood supply. So please inspect all the bowel. Please identify and correct malrotations. If malrotation is present, identify the site of the obstruction, dilated and the collapsed part, exclude malrotation and the mid-gut volvulus, then decide to perform primary anastomosis in the absence of peritonitis, in the absence of volvulus, in the absence of contaminations. If there is site of perforation, isolate these sites and avoid more contamination. Stoma is used very minimally in this baby because it is associated with high output electrolyte disturbance, may make more problems. So the primary rule is to perform primary anastomosis. Mesenteric defect repair, searching for distal atresia by cannulating the distal collapsed intestine, injecting warm saline to detect any further atresia. Transosmotic feeding tube is optional, however, it is very important. Allow early feeding to act as adjuvant to the post-operative nutritional support. Particularly, we speak about small birth weight or premature neonates, so may have to help them to bypass these critical periods in addition to the TBN. Other surgeons prefer to start TBN and not to insert anastomotic tube. However, if there is a gross dilatation of the proximal bowel or if TBN is not available, you are in need to insert this trans-anastomotic tube. What to do with operative challenge? The first operative challenge is like these pictures. The presence of hugely dilated proximal bowel and distal small intestine. Hugely dilated proximal bowel with suspected potential dysmotility. You need to resect this bowel. Yes, the first option is back resection to normal caliber bowel. However, if sufficient residual length present. However, if there is a long segment and I resect all dilated segment, I leave this baby with catastrophic short bowel syndrome. So the ideal route is to resect, or what's called back resections, to near normal caliber, to reach normal intestine to anastomose with the distal, so you perform the same caliber anastomosis. However, you need sufficient residual length. So we return back to the point of measuring the bowel length at the start of the surgery along the anti-mesenteric border and reporting it in the operative report. If long segment of the proximal intestine significantly dilate, the resections of the whole involved segment may result in short bowel syndrome. In these cases, we have two options. We may perform what is called tapering enteroplasty or plication. You say that this is plication of the intestine. We take sutures to reduce the caliber, invaginate intestine inside. So you don't resect anything. You just invaginate. This invagination will reduce the caliber to the same caliber of the distal bowel. Or you may resect a strip on the anti-mesenteric intestine, rise this strip, and then close or realign the both ends of the incision together, so you reduce the caliber. But this is reducing size procedures. But the first option is a back resection if you have sufficient length. If you don't have sufficient length, or there is a long segment affected of the bowel, you may need to perform tapering enteroplasty or plication of the intestine. The tapering enteroplasty by resecting anti-mesenteric strip of the dilated proximal bowel, tapering can be performed very safe up to 35 cm or as far as the second portion of the duodenum if you have high jejunal obstruction. Tapered bowel may be then anastomosed to the distal bowel or externalized as a stoma if you need that. The second operative challenge is the marked bowel discrepancy. Also obvious in these pictures, in the previous pictures, marked bowel discrepancy. This is dilated and this is very small. How to anastomose this with this? How to anastomose the balloon with just small ring. So we may have gentle dilatations of the distal bowel end with normal saline injections. You can apply non-crushing clamp about 5 to 6 cm distal and injecting saline here in the distal bowel to make what's called some form of dilatation or stretch to the distal bowel. However, avoid injury to the serosa. Or we may perform what's called oblique resection or incisions of the distal bowel along the anti-mesenteric border to create what's called fish mouth opening. So you have two solutions for this problem, for the size discrepancy. You may perform gentle dilatation of the distal bowel. How? You apply non-crushing clamp about 5 to 6 cm distal in the distal collapsed bowel and inject saline. This saline will dilate and stretch the distal bowel, however, avoid injury to the serosa. The second option, you may make a longitudinal cut along anti-mesenteric to widen the distal opening and create what's called fish mouth opening. As we see, this is dilated and this is collapsed. However, these techniques can help to resolve the discrepancy in size of the bowel lumen up to 8:1. So imagine that if the proximal is 8 times the size of the distal, this tapering, this fish mouth, creation of fish mouth or stretching or dilatation can solve this problem. However, early return of the normal peristalsis reported with the lumen discrepancy of 4:1. So try to reach this percent. After your dilatations or back resection, try to make the proximal as 4 and the distal is 1. However, the options given to you already help you to solve 8:1. What we need is to reach the level of 4:1 to report to have your baby with early return of the normal peristalsis. Atresia just distal to the DJ junction, to the duodenojejunal flexion. What to do with this atresia? Reported that resect the dilated bowel up to the third part of the duodenum and derotate or strengthening the duodenum and taper the duodenum to avoid kinking of the anastomosis. So you don't leave the duodenum in its usual orientation, straight this duodenum to allow easy passage from the gastric content downward to a straight duodenum. Care must be taken to protect the pancreas and ampulla of water when you're working in such case, in this certain position. Multiple atresia. What to do if you have baby or newborn with multiple atresia? The first solution, if these multiple atresias is very close to each other, you can resect all with one anastomosis, which is very important if sufficient intestinal length remain. If there is sufficient functional intestinal length, you can remove all the atretic part, not to perform multiple anastomosis, remove all atresias and perform single anastomosis between the distal proximal patent and the distal patent one. If involving multiple segment, atresia not localized short segment, no, involving multiple segment, you can insert an esogastric tube through the atresia and perform anastomosis all over this tube. This will facilitate performing the multiple anastomosis and will act as a stent during the post-operative period, which is very important. Patients that require multiple anastomosis may show long-term delay in the return of the intestinal function, sure. In addition, many patients will have short bowel due to inadequate residual intestinal length. In case of apple peel deformity, when you face a baby or neonate with apple peel deformity type 3B, the bowel should be displaced in the position of the non-rotation, keeping the free mesenteric border. What does this mean? Means that you put the small bowel in the positions of the non-rotations. You create position of non-rotation like what's happened in LAD procedure. We put the cecum and the colon on the left side, and the intestine on the right side, was called position of non-rotation. All restrictive band, if there is any bands all over the intestine or active peel on the intestine, must resect this fibrotic band to allow this to be free edge to avoid vascular compromise. The problem here in such cases is that the presence of these bands or fibrotic bands may cause ischemia in such cases of the upper bile deformity. So the bowel should be displayed in the position of the non-rotation, keeping free mesenteric border. All restrictive fibrotic band along this free edge should be divided prior to the primary anastomosis to enhance the blood supply and the venous drainage in this situation. The mesentery from any resected bowel is retained and may assist in the closure of the mesenteric defect. This is very helpful and they prevent kinking or distortions of the anastomosis. Bowel should be returned to the abdomen with careful inspections to the mesentery to prevent torsions of the single marginal artery and vein. So the cases of the upper bile or Christmas tea or type 3B atresia carry a significant importance in dealing with it. You must preserve the single supplying artery and vein. You must remove all the restricted bands all over the intestine to avoid the ischemia. You must avoid kinking or torsions of these single vessels. You must put the intestine in non-rotation position. Infant with short bowel syndrome. If you have an infant with atresia and short bowel, the bowel lensing procedure such as a serial transverse enteroplasty or lensing and tailoring not recommended as an initial surgery. It is wise to allow for the intestinal adaptations and allow for the enteral feeding to take place. Regarding formation of the stoma, usually or generally unnecessary because the dilated bowels doesn't reduce in size caliber. Doesn't reduce, still be dilated after formation of the stoma. Also, there will be fluid and electrolyte loss, which may be so severe in these neonates. The indications may be gross intraperitoneal contamination or volvulus or vascular compromise or the presence of meconium means. In such cases, you can perform temporally stoma, externalize the bowel to the abdominal wall. Jejunal atresia associated with gastroschisis. You may have a baby or newborn with a gastroschisis and there is atresia. So there is two options. Number one, resection and the primary anastomosis. You resect and perform primary anastomosis if there is limited edema and matting from the amniotic peritonitis. However, if there is marked edema and matting, this initial resection and the primary anastomosis may not be helpful. So initial reductions, the second option, reductions of the eviscerated bowel with leaving the atresia undisturbed and the primary closure of the abdominal wall defect until the marked edema and matting disappear. After the facial closures, you can perform gastric decompressions and the TBN support subsequent laparotomy. So in gastroschisis, atresia with gastroschisis, you have two options, whether to perform a primary anastomosis of both ends and close the gastroschisis if there is minimal edema and meconium peritonitis or matting of the intestine. Otherwise, you will reduce the atresia inside, close the gastroschisis, insert an esogastric tube, and after 4 to 6 weeks later, you can reopen and re-anastomose this atretic part. In case of the stenosis, it is important that enteroplasties or excisions or bypass technique not recommended in patients presented with stenosis, as these procedures usually fail to remove the dysfunctional segment. So in stenosis, if they're diagnosed, you can manage them with removal of this stenotic and short segment. The post-operative care, TBN, should begin as soon as possible and continue until the infant tolerating the enteral feeding. Enteral feeding initiated with clear minimal gastric aspirate at about 20 milli per kg per day of the breast milk or formula in a continuous fashion. Feeding increased by 20 to 30 milli per kg per day. Oral intake initiated when the baby is alert, able to suck, and tolerating at least 8 milli of the tube feed per hour. The transient gastrointestinal dysfunctions frequently observed in infant with jejunal and ileal atresia. Etiology is multifactorial, may be related to lactose intolerance or malabsorption with stasis and bacterial overgrowth. So these neonates or newborn may have transient gastrointestinal dysfunctions, may have a diarrhea, especially with type 3B atresia or with short bowel syndrome. The management of the altered or disturbed gastrointestinal function that may be hastening the adaptation of the intestine may be related to the use of the loperamide hydrochloride, cholestyramine, and vitamin B12 and folic acids, very essential to the babies without terminal ileum to prevent megaloblastic anemia. So this post-operative care is very important to stress on the TBN, to know that this baby is vulnerable to the development of transient gastrointestinal dysfunction, to the development of diarrhea, especially for type 3B or Abel-Bill or Christmas tea. These babies may have to use to support or to alter adaptations of the intestine, the loperamide hydrochloride, the cholestyramine, the vitamin B12, and the folic acid. This is very important and essential information you must know about the post-operative care. The prognosis, usually the normal small intestinal bowel in length in the term neonate is about 250 cm. Previous estimate that the small bowel length of 100 cm or more is necessary to sustain oral intake and survival is no longer be applicable because of the development of the TBN, special enteric diets, pharmacological management. So even neonates with very little or very small amount, less than 100 cm, can survive and can pass the post-operative period safely. The functional outcome of your surgery and of the repair ultimately depend on, number one, the location of the atresia. It was found that ileum adapt greater than the jejunum. Number two, the maturity of the intestine. Found that small intestine, the premature infant, still has a time for maturation and growth. Number three, the length of the small intestine. Very important. However, despite you measure it, it's very difficult to determine it accurately. The ileocecal valve. Please, ileocecal valve is critically important. Try to preserve it. It allows rapid intestinal adaptation when the residual small bowel length is short. So this is the functional outcome of the baby's repaired jejunal-ileal atresia. The location, the maturity of the intestine, the length of the functioning small bowel, remaining bowel, the ileocecal valve, presence or absence of the ileocecal valve allow faster adaptation of the intestine, very important. The third atresia we have today is the colonic atresia. Atresia of the colon, it is a rare cause actually, reported in about 1 in 5,000. Vascular insult to the colon also may be the etiology for the colonic atresia. Also 3 types as previous one. Type 1 mucosal atresia with intact bowel wall, type 2 atretic end separated by the fibrous cord, type 3 atretic end separated by V-shaped mesenteric cap. Associated anomalies, usually there is association with gastroschisis, urological abnormalities, multiple small intestinal anomalies, atresias, and skeletal anomalies. Clinically, there will be marked abdominal distension. This is a distal obstruction, but otherwise develops in the first 24 to 48 hours. Bilious vomiting, not early symptoms, yes, because it's a distal intestinal obstruction, and failure to pass meconium. On examination, the abdomen will be more distended, slightly tender, with visible bowel loops. Colonic atresia is sometimes associated with abdominal wall defects like gastroschisis, cloacal extrophy, or rarely omphalocele. This is the plain X-ray. There will be multiple air fluid levels and dilated loops. Dilatation can mimic the pneumoperitoneum. Also, there is maybe right-sided large loop like this, corresponding to the proximal dilated colon, may be characteristic for patient with colonic atresia. However, we say that it's impossible to differentiate between small intestine and the colon in the neonates. The contrast enema is very important. We'll show a small colon caliber with sudden stop at the site of the obstruction or site of the atresia. This is called diagnostic of the colonic atresia. provided that you perform the dye well with adequate pressure so that this site will actually represent the site of the obstruction. Preoperative management for the babies with colonic atresia will be the same: corrections of the fluid and the electrolyte abnormalities, gastrointestinal decompression, prophylactic antibiotics. The operative approach will be the diagnosis of the colonic atresia. This is very important, requiring urgent operation to avoid the risk of the perforation. The operative approach depends on the clinical status, the level of the atresia, the associated small intestinal atresia, the patency of the bowel distal to the atresia. At the time of the initial operation, it is important to exclude other intestinal atresias and the stenosis associated Hershey-Spark. Although it's very rare, however, you must perform frozen sections or you must perform rectal biopsy to avoid anastomotic leakage or functional obstruction. Operative principles: many surgeons differentiate between colonic atresia distal and proximal to the splenic fracture. So we may have colonic atresia distal to the splenic fracture and proximal to. Proximal to the splenic fracture, primary section anastomosis is the rule. However, distal to the splenic fracture, colostomy with delayed closure is the rule. Staged approach may be described also with creations of the colostomy and the mucus fistula. In cases of questionable bowel viability, colonic perforation or peritonitis, patient with associated abdominal wall defects. As we see, this is form of the colonic atresia, and this is the appendix here, and the distal colon. You can observe how the colon is dilated and the distal colon is very narrow. In uncomplicated cases, primary section anastomosis. However, anastomosis may be technically difficult because of the marked bowel discrepancy. You can see this is dilated proximal bowel and collapsed distal. You need to anastomose this to this very difficult anastomosis. Transanal approach recently reported with repair of the rectal and sigmoid atresia after initial colostomy at birth, followed by the transanal repair 3 to 6 months later. Closure of the colostomy was done only 2 months post-repair. The prognosis related to isolated colonic atresia: excellent prognosis if diagnosed early. Delay of the diagnosis may result in high mortality, may be related to the closed loop obstructions between the ileocecal and the atretic part and lead to massive colonic distensions and may be perforation. So delayed diagnosis will carry a high mortality. Now we will shift to an important part of this lecture today, which is how to approach neonate with bowel obstruction. We speak about duodenal atresia, we speak about jejunal-ileal atresia, colonic atresia. All these obstruct the intestine for the neonate. Previously, we speak about the meconium ileus. We also have colonic Hershey-Spark disease and total colonic aganglionosis. So how to approach, how to think for a neonate with bowel obstruction? Let's start. Any newborn with a bilious vomiting, abdominal distension, and failure to pass meconium should be evaluated for bowel obstruction. Very clear. The second important one: any bilious vomiting in a previously well newborn is considered malrotation with mid-gut volvulus until proved otherwise. So any bilious vomiting in a previously well newborn, consider malrotation and mid-gut volvulus. Why malrotation and mid-gut volvulus is important? Because it carries significant and catastrophic bowel infarction. If you don't diagnose, or if you miss the diagnosis of malrotation and mid-gut volvulus, you will lose all the length of the intestine. How to diagnose the level and the etiology of the obstruction? Diagnosis will depend on the clinical presentation, physical examination of the neonate, and radiological diagnosis. So bilious vomiting, distension, failure to pass meconium, obstructed newborn. How to diagnose the level? Where is the obstructions? Upper, middle, lower gastrointestinal. By the clinical presentation, by the physical examination, radiological diagnosis. Clinical presentation of the neonatal diagnosis: usually there will be vomiting or bilious vomiting, feeding intolerance, abdominal distension, failure to pass meconium, or in complicated cases may be peritoneal signs of peritonitis. However, the symptoms and signs may not be reliable to discriminate all causes of the obstruction, although they can provide clue to the most underlying etiology. Bilious vomiting. The proximal obstruction, suspect you have a proximal obstruction, there will be early onset vomiting. Duodenal atresia, duodenal stenosis, proximal jejunal obstruction. In distal obstructions, ileal and chronic, you will have delayed onset vomiting with marked abdominal distension. In mid-gut volvulus, usually present with sudden onset of bilious vomiting after initially tolerating feed. Bilious vomiting and mid-gut volvulus. Bilious vomiting not a reliable discriminator for the presence of mid-gut volvulus. However, some neonates with bilious vomiting don't have mid-gut volvulus. Presence of the bile simply reflects that the obstruction is distal to the ampulla of water. So even in the presence of the bilious vomiting, you cannot argue that there is a mid-gut volvulus in 100%. Abdominal distension, we said that marked abdominal distension associated or suggestive of distal obstruction. The distal ileum or the colon obstructed. However, in rare cases, this marked distension may be not secondary to the obstruction, but rather to an ileus, secondary to ischemia or infarction or mid-gut volvulus. So even in the with distal, with marked abdominal distension, you may have mid-gut volvulus ischemia and infarction. So this is very important point. Failure to pass meconium will give you additional clue to the diagnosis. Failure to pass meconium suggests complete distal obstructions. However, infants with Hirschsprung disease or some functional obstruction might pass a small amount of meconium. So our problem here is number one, neonate with obstructions, abdominal distension, bilious vomiting, failure to pass meconium. You need to diagnose the level and the etiology of the obstruction to exclude mid-gut volvulus. This is your job. The physical examination of the newborn, not always reliable discriminator also. Even in the mid-gut volvulus, the abdomen is initially soft and not tender until ischemia develops. There is maybe this early benign physical examination justify that there must be a high index of pediatric surgeon suspicion to avoid catastrophic bowel infarction. So it is very important for the pediatric surgeon to be alert in excluding the mid-gut volvulus and malrotation in babies with neonatal intestinal obstruction. The radiological diagnosis of neonatal intestinal obstruction, we speak about the prenatal ultrasound in duodenal atresia, in jejunal-ileal atresia, in chronic atresia. Diagnose many congenital bowel obstructions. However, still, diagnostic pitfalls are well documented and require postnatal imaging workup before surgery. So we have a clinical presentation, we have a physical examinations and radiological diagnosis. Clinically, bilious, distensions, and failure to pass meconium. Physically, initially, there will be no signs diagnosing mid-gut volvulus. Later may be developed with peritonitis. And radiology. Radiology is very important, and all pediatric surgeons must familiarize themselves with the interpretations of these radiological investigations. The postnatal radiological diagnosis will be plain X-ray, ultrasound, upper gastrointestinal study, and contrast enema. Pediatric surgeon should be familiar with radiological interpretations. The first order radiology is a plain abdominal X-ray. When you call to see a neonate or baby with bowel obstructions, the first order you order, please, I need a plain X-ray abdomen. What do you suspect to see? Number one, maybe normal. Means gas distributed uniformly throughout non-dilated stomach and bowel, like this picture. Normal. You see the X-rays, normal. it might seem reassuring. I have a normal abdominal X-ray. However, if the bilious vomiting or suspicion of malrotations with mid-gut volvulus is present clinically, you must proceed to upper gastrointestinal study, not become reassured by this seeming normal plain X-ray. Number two, you may see this presentation, double bowel sign. We describe it with duodenal atresia, and it seems to be diagnostic for duodenal atresia. Double bowel sign, dilated stomach and duodenum, like this. Dilated stomach and duodenum, this is the air in the pylorus, with no distal gas. So in such cases, it seems that upper gastrointestinal study is unnecessary because the contrast will not characterize the abnormality any better than the air. However, the critical question is still present. Is this pattern warrant any concern for the midgut volvulus? There is a considerable debate about is these babies with a plain X-ray showing double bubble sign with no distal air still carry a risk for the midgut volvulus? What is the importance? There is a large importance because duodenal atresia is an elective surgery. However, midgut volvulus is an emergent surgery. So what can you do? Your baby present with X-ray showing double bubble sign. You make it either like urgent surgery or you make it with an elective surgery. So some authors claim that if you suspect clinically that there is minimal distension, that there is maybe bilious vomiting or suspicion of malrotation, please perform upper gastrointestinal contrast. You may be faced with single bubble with no distal gas. As we said, this is single bubble X-ray, no distal gas. We describe these pictures, previous lectures, in a rare case of what's called pyloric atresia. However, if you need to decide that this is a single bubble with no distal gas, diagnostic of pyloric atresia, please perform subsequent radiograph. Repeat the X-ray, number one. Number two, please inject air, 10 to 20 milli of air through the nasogastric tube. You may have three possibilities. You may have a single bubble with distal gas, so in such case, upper gastrointestinal contrast is mandatory. Or you may have true double bubble, so this is a duodenal atresia. Or you may have a true single bubble, so this is a rare gastric atresia. So be cautious that the interpretations of the plain X-ray may not depend on a single X-ray. May be related to the gas distribution through the gastrointestinal tract, may take some time. The triple bubble, shortly we describe it, stomach, duodenum, and jejunum. The triple bubble is indicative of jejunal atresia. If all the three loops are not dilated or confused, please perform upper gastrointestinal contrast to exclude midgut volvulus. Also, the contrast enema to exclude additional colonic atresia. In babies with triple bubble, you need, if you don't found that this triple bubble is well dilated, representing stomach, duodenum, and jejunum, you need to perform upper contrast. Also, you need to perform the contrast enema to exclude additional colonic atresia. Why colonic atresia? Because we say that intestinal atresia or jejunal and ileal atresia is related to vascular insult. Also, colonic atresia related to vascular insult. So both atresias may share the common etiology. So if you suspect one, please search for the second atresia, which may change your operative plan. Or you may found obstruction with meconium ileus, or you may found that there is colonic atresia. Unlike duodenal atresia, is because associated duodenal atresia related to the failure of recanalization. You may find single bubble with distal gas, very common finding in the neonates. However, in the presence of the bilious vomiting, consider it as the red flags or dangerous sign and perform upper GI examination in this clinical setting. You may be faced with a double bubble with distal gas, like this, double bubble with the presence of the distal gas. We speak shortly about it in the diagnosis of duodenal stenosis. However, the presence of the distal gas indicate whether the presence of the duodenal stenosis, number one, bifid common bile duct with one inserted above and below the atresia, or the presence of catastrophic mid-gut volvulus. So please perform upper GI examination when you find X-ray with double bubble with fainty or even scanty amount of distal gas. You can find the picture like this, diffusely dilated loops. It is impossible to differentiate between the colon and the small intestine, ileum or colon. Obstruction here may be related to the ileum and the colon, so perform the contrast enema. Contrast enema will differentiate. If there is the contrast stop at sudden abrupt in the colon, this is chronic atresia. If the contrast can go up to the ileum or stop at the obstructions the ileum, this is ileal atresia. However, take care that in ill infant, the dilated loops, we said that these dilated loops may not be secondary to obstruction, but rather secondary to an ischemia or infarction. The final one is to see dilated scattered bowel loops, like this. Dilated scattered bowel loops, featureless, scattered randomly throughout the abdomen. It's called sick belly, seen with the distal obstructions or with proximal obstructions or in utero examination. In such cases, you must perform upper GI study. So all of these presentations are radiological presentations of X-ray. You may see single bubble. Please confirm that it's short single bubble, not double bubble or double bubble with distal gas. You may find the double bubble. You may find triple bubble with distal gas or without distal gas, or dilated loops or not dilated loops. You may find diffuse dilatations of all loops, suggesting distal obstructions, so perform the clonic enema. How found dilated scattered bowel loops. Upper GI study. Also upper GI study, when we speak about it, we may have a normal upper GI study. Normal trombid gastric emptying, normal caliper duodenum, and normal positions of the duodenojejunal flexures. The duodenum cross to the left of the left vertebral body. Crossing to the left side, okay. Exclude structural causes of the obstructions. We may show the picture like this, malpositions of the DJ junctions, malpositions. The junction normally cross to the left will be found on the right side. So this may explain that the bilious vomiting in this baby may be related to intermittent mid-gut volvulus, indicated for emergent surgery in infant with bilious vomiting. But so the first presentation may be normal. Second one, malposition of the DG junction. The third one is what's called corkscrew duodenum. You find that the duodenum follow a straight course, spiral inferiorly, without crossing the midline or to the left of the vertebral. This is diagnostic. This is diagnostic of mid-gut volvulus and require emergent surgery with detorsion and delayed procedure. So that the presence or appearance of the corkscrew duodenum is very important. Complete duodenal obstruction, like corkscrew duodenum, indicates the need for the emergent surgery. You see that the upper dye study follow and stop abruptly in the duodenum. Need time to wait to allow for the dye to pass during the procedure performance. However, it is suggestive and indicates that there is a need for emergent surgery. So this is maybe related to corkscrew. However, the twist of the intestine is more tight, so obstructing the complete flow rather than performing the corkscrew or the spiral presentation of the duodenum. Persistent duodenal narrowing with normal DG, like this. This is segment narrow of the duodenum with normal DG junction, indicating the partial obstructions or compressions extrinsic by the lead procedures or intrinsic by the duodenal web. However, the upper dye study cannot diagnose accurately what are the causes. However, they indicate that there is an extrinsic obstruction or what's called there is partial obstruction. Partial obstruction may be extrinsic or intrinsic. Upper dye study will not document the cause 100%. However, with the presence of the normal positions of the TJ, you can say that the malrotation and volvulus is maybe excluded and there is no need for emergent surgery. So in the upper dye study, we depend on the presence of the size of TJ and the appearance of the corkscrew appearance of the duodenum. Very critical, two important findings indicate emergent surgery. Regarding the contrast enema, the finding may be microcolon. Microcolon is small caliber colon. Normal fetal colon is distended by the meconium and the sloughed cells and the secreted fluid. Distal ileal obstructions prevent sufficient bowel content to reach the colon, leaving it narrow and non-distensible, called microcolon. So this is called microcolon. What are the causes? Maybe meconium ileus or ileal atresia. How to differentiate? If refluxed contrast reaches the ileal loop containing multiple filling defect, it is a meconium ileus. If the reflux cannot beyond the small caliber ileum, it is an ileal atresia. Very rare total colonic Hirschsprung may give the same pictures of the microcolon. So the appearance on the barium enema of microcolon may be related to two differential diagnoses, maybe meconium ileus and ileal atresia. Obstruction at the terminal ileum preventing any content to distend the colon. How to differentiate? Differentiation related to if the contrast, when you perform the enema, the contrast material can reflux into the distal ileum containing meconium pellets. This is diagnostic of the meconium ileus. Cannot reflux into the dilated proximal intestine. This is intestinal atresia. Also, you can join this finding with the presence of the plain X-ray. In meconium ileus, you will find dilated multiple loops without air fluid level, as the presence of the meconium prevents the formation of air fluid level. However, in distal atresia, you will find multiple dilated bowel loops containing air with formation of fluid level just above the atretic point. So we put all clinical findings together to reach the diagnosis. The second finding may be related to short microcolon. So there is a microcolon and stop here. This is diagnostic of the colonic atresia. We say that colonic atresia inject the dye and stop at the site of the colonic obstruction, provided that you inject the dye adequately with adequate pressure. The arrest of the dye will represent the site of the obstruction in the colon. The third finding in the colonic contrast enema is a colon caliber change. You inject the dye and find narrow colon, then dilated. What is this? The differential diagnosis is also maybe Hirschsprung disease or maybe small left colon syndrome. And both are functional obstructions. As we said, this is the rectum, this is the small or short microcolon, and this is a dilated transverse. In such cases of the small colon caliber syndrome, the rectum appears dilated, and usually the dilatation of the colon starts at the splenic flexure. In Hirschsprung, classically present rectosigmoid. However, overlap is sometimes present. So this is described as finding as colon caliber change. In small left colon syndrome, caliber change usually as the splenic flexures and usually meconium evacuation follow the contrast within 24 to 48 hours. In Hirschsprung, classically at the rectosigmoid, however, rectal biopsy is the only diagnostic investigation. Normal contrast enema. If you find normal contrast enema, what you do? Normal contrast enema should not be reassuring. Immediate concern should be shifted to the exclusions of the malrotation with upper gastrointestinal study. So, bilious vomiting, abdominal distension, baby or neonate with normal contrast enema, you must reassure the upper contrast study. Also, you must reconsider the Hirschsprung disease. Why? Because the contrast enema is interpreted as normal in about half of the cases of total clonic Hirschsprung disease. Also, there is maybe delicate or fine change in the caliber not appreciated or not observed in the short segment, ultra short Hirschsprung disease. So with normal contrast enema, baby obstructed newborn with vomiting and distension, and the enema is normal. Consider upper to perform upper contrast study, and then consider Hirschsprung disease or total chronic agangliosis and perform rectal biopsy. Rectal biopsy should be considered to diagnose. Now, to summarize, we will go what's called pattern-based diagnosis of the common obstructive lesions. We can review rapidly all what we said in the following slides. Number one, early onset bilious vomiting, minimal abdominal distension, delayed passage of meconium. Plain X-ray showing double air bubble with no distal gas. 1 second, no distal gas. In such cases, please, upper gastrointestinal study may be performed by some surgeon for medico-legal diagnosis, or if they suspect that there is tiny or possible distal gas. This is a dye study. Upper and dilated and lower dilated. This is diagnostic for duodenal atresia. So this is the diagnosis of duodenal atresia at glance, or the diagnosis, pattern-based diagnosis. Number one. Number two, early onset bilious vomiting, minimal abdominal distension, delayed or non-passage of meconium, suspecting high obstruction. We perform plain X-ray, double bubble air with scanty distal gas. This is the first, and the second double, scanty distal gas. In such cases, upper gastrointestinal study is mandatory to exclude the midgut volvulus and the malrotation. Duodenal stenosis or duodenal atresia or bifid common bile duct may give the same presentation, or maybe malrotation or midgut volvulus, the corkscrew appearance of the duodenum, like this dye study. In duodenal obstruction, usually duodenal atresia associated with malrotation in about 30%. Some authors claim that duodenal atresia will act as a floodgate or prevent the development of volvulus, of midgut volvulus, because midgut volvulus need the content to pass in the intestine already mal-positioned or non-rotations, so they can rotate around the short mesentery. Some authors claim that presence of the duodenal atresia prevent the development of midgut volvulus. So in such cases, when you find a double bubble with distal gas, you must perform upper contrast to exclude malrotation and the midgut volvulus, or you can find the same presentation. Explanation for this distal gas may be duodenal stenosis or atresia with bifid common bile duct. Type. Antenatal history of polyhydramnios, bilious vomiting, abdominal distension, plain X-ray, found a few number of the dilated air-filled loops of the small bowel with no further distal gas, and the air fluid levels just proximal to the atresia. In such cases, also, we need to perform upper GI contrast to exclude malrotations and the midgut volvulus, maybe proximal jejunal atresia giving the same presentation, or maybe the malrotation with midgut volvulus giving the same presentation. So it's very important in any neonate or newborn presented with high gastrointestinal obstruction, early onset bilious, minimal abdominal distensions, you must consider to perform upper GI study to exclude associated catastrophic malrotation with midgut volvulus. Very essential and very important, unlike the distal obstruction. In the case of distal obstruction, the air already passed the midgut and reach the hind gut. In such cases, our thinking will be shifted to the lower contrast or the contrast enema. As this case, late onset bilious vomiting, marked abdominal distension, plain X-ray showing greater number of the dilated air-filled loops, small bowel with air fluid level just proximal to the atresia, Now we will think about to perform the contrast enema. The contrast enema, unused microcolon with failure to reach the dilated proximal bowel, diagnostic of distal ileal atresia. This is the first priority, distal ileal atresia, maybe clonic atresia, maybe meconium ileus, giving the same presentation. So clonic atresia, also late onset bilious vomiting, marked abdominal distension, plain X-ray, multiple dilated loops with air fluid level, large right-sided loop corresponding to the proximal obstructions. Contrast enema will show microcolon with sudden stop at the site of the clonic atresia. This will be diagnostic. So in a baby or neonate with early distensions, late onset bilious vomiting, multiple dilated loops reaching the lower abdomen with gasless pelvis, consider clonic atresia, distal ileal atresia, meconium ileus. However, we previously said that in rare cases, this presence of dilated multiple loops may not related to the obstructions, it may rather related to late cases of mid-gut volvulus with distension and dilatation secondary to ischemia. So please take care and be cautious. Meconium ileus. Also, baby with marked distension, late onset, will X-ray will show dilated loops without air fluid level, as a sick meconium prevent the air fluid level, soup bubble or ground glass, meaning mix of the air with sick meconium, like this. This is soup bubble or ground glass, soup bubble or ground glass with dilated loops. In such cases, the contrast enema will show multiple filling defect in the microcolon. If the contrast can reach the distal ileum, there will be meconium pellets will appear. So the contrast enema will differentiate between distal ileal atresia, clonic atresia, meconium ileus. Also, meconium black syndrome will be dilated bowel loops without air fluids. The contrast enema will show small microcolon with normal caliber of the rectum and the transverse colon with multiple filling defect. Usually, these cases relieved and treated after BR or a small limited enema. In what's called small left colon syndrome, the baby will present with marked distensions, with bilious vomiting, dilated bowel loops with the air fluid levels, and the contrast enema will show the small microcolon with change of the caliber, usually at the splenic flexures, and there will be little dilated rectum. So this will be diagnostic and dilated transverse colon. So you can divide the neonates in two groups. The proximal obstructions, your consider will be to upper contrast study at first. Distal obstructions, your consider contrast enema at first. If there is normal, you can shift to upper contrast study, or otherwise you can diagnose and differentiate between small left colon syndrome, distal ileal atresia, clonic atresia, and meconium ileus, meconium plug, Hirschsprung disease. In Hirschsprung disease, also the same presentation, late onset bilious vomiting, failure to pass meconium, signs of distal obstruction with dilated loops, fluid levels, airless pelvis. The contrast enema will show usually the transitional zone at the rectosigmoid in classic cases. However, rectal biopsy is the sure diagnostic method. In certain cases of the total clonic aganglionosis, ultimately it is very rare cases. There is a baby will present with also distal obstructions with air fluid level. The diagnostic finding on the clonic or contrast enema will be what's called question mark sign. Question mark shaped colon described as rounded, shortened contour of the hepatic and the splenic fixture with short appearing colon, like this mark, question mark. You can imagine that this is the same characteristic. If you see this question mark, however, the entity is very rare, as it is very rare. However, this question mark described well in the contrast enema of total clonic aganglionosis. If the baby is neck or necrotizing enterocolitis, you will find that this is in a preterm unit, systemic signs of sepsis, feeding intolerance, high gastric aspirate, abdominal distensions, and the plain X-ray initial finding will be non-specific, dilated loops of the intestine and the bowel, similar to the ileus. maybe portal vein gas or pneumoperitoneum or fixed loop, and this is late and advanced signs. So in conclusion, we can classify the neonatal obstruction into high obstruction or proximal. In such cases, will be early onset bilious vomiting, minimal abdominal distension, and the abdominal X-ray will show few gas-filled and fluid-filled loops of the small bowel with no further distal gas. In such cases, the differential diagnosis in the upper part will be related to duodenal atresia, stenosis, proximal jejunal atresia. However, malrotation and volvulus still present by an important part. Upper contrast is mandatory to exclude the malrotation and volvulus once significant other systemic anomalies are excluded, cardiac or other anomalies. Infant prepared rapidly for surgery and exploration. If the obstruction is distal, the newborn who is present with or low intestinal obstruction, late onset bilious vomiting, marked distension, abdominal X-ray, many loops of the air-filled and fluid-filled bowel. In such cases, the differential diagnosis is more complex. Maybe distal ileal atresia, clonic atresia, meconium ileus, Hirschsprung disease, small left colon syndrome, meconium plaque syndrome, adynamic ileus means sepsis or drug toxicity. Contrast enema is done first. If no pathology, upper contrast study is required, then surgery will be determined. In final, this is the final algorithm. Very important that neonate with intestinal obstruction. What meaning by intestinal obstruction? Bilious vomiting, distension, failure to pass meconium. We have two groups, whether early bilious vomiting with minimal abdominal distensions, suspect high intestinal obstruction or proximal. Late bilious vomiting, marked abdominal distension, suspect low obstruction. In both cases, start with plain abdominal X-ray. This plain X-ray may show single bubble, diagnostic of pyloric atresia, provided that you see subsequent X-ray, you inject air, 10 to 20 milli of air, to be sure that there is only single bubble. Or you may find the double bubble with no distal gas, diagnostic of duodenal atresia, provided that the bubbles are well dilated. You can reproduce the bubbles by injecting air as a contrast. In such cases, there is a debate to perform upper contrast study or not. However, double bubble with distal gas, you must perform upper contrast study. Dilated scattered loop, you must perform upper contrast study. The upper contrast study may show, number one, abnormal duodenojejunal flexions, diagnostic of midgut volvulus malrotation, urgent surgery. Number two, corkscrew appearance, spirally rotated inferior duodenum, diagnostic for malrotation with midgut volvulus, urgent surgery. It may show duodenal obstructions, segment of the duodenal obstructions with normally positioned DJ junction. In such cases, elective surgery. Normal obstruction may be related to intrinsic fenestrated web, may be related to annular pancreas. May show partial obstructions with normal duodenojejunal flexions. Okay, but this is four possibilities for the upper GI: abnormal duodenojejunal fracture, corkscrew, or duodenal obstructions, complete obstructions of the duodenum. Is this complete obstruction of the duodenum the same as corkscrew, need urgent surgery? Or partial obstruction duodenum with normal duodenojejunal fractures? In such cases, elective surgery. So return to the X-ray. Dilated scattered loop, diffusely dilated loops. Start with a contrast enema. Start with a contrast enema. You may find microcolon. Microcolon may be meconium ileus or ileal atresia. Differentiate by meconium ileus and ileal atresia by that in the meconium ileus, the microcolon, if reflux occur into the terminal ileum, we'll find billets of the meconium or filling defect of the meconium. Put the finding in the X-ray, plus that there will be multiple dilated bowel loops without air fluid level, as the meconium prevents the formation of air fluid levels. Number two, the air will mix with the meconium, giving the soup bubble appearance. Number two, short microcolon, consider clonic atresia. Clonic atresia, we inject the contrast enema, stop at the site of the obstruction. Number three, calibrate change. In calibrate change, consider Hirschsprung disease or a small left colon syndrome. Differentiate as a small left colon syndrome. Usually there is dilated rectum followed by small left colon ending usually at the splenic flexion. In Hirschsprung disease, there is usually the transitional or calibrate change, usually at the rectus sigmoid. If you find on the X-ray triple bubble, consider jejunal atresia, provided that there is well dilated stomach and duodenum and upper jejunum. So this protocol is very helpful, and this algorithm is very helpful how to deal with neonate with bowel obstruction, how to seek. From the start, classify your neonates in two parts: early bilious, minimal distension, suspect high obstruction. In such cases, malrotation and midgut volvulus must be excluded. Late bilious and marked abdominal distension. The first radiological investigation in both cases, plain X-ray, and according to the finding, you can decide whether to perform first upper contrast and lower contrast. One can say that we can perform both together. There will be an overlap. If you perform upper contrast and lower contrast enema in obstructed baby, you cannot differentiate. You will find dye. This dye coming from above or coming from below. So the priority to start with upper gastrointestinal contrast in a proximal obstruction, start with clonic in a distal. However, putting in consideration with normal contrast enema, you may need to perform the upper contrast again. This is very important lectures today, and must be all pediatric surgeons be familiar with these types of obstruction. So today we speak about the duodenal atresia and stenosis, jejunal-ileal atresia and stenosis, clonic atresia, and then we go to how to approach neonate with bowel obstruction. Pediatric surgeon frequently asked to come to the incubator to see a neonate with bowel obstruction. In such cases, you must follow an organized or pattern system. You must follow: is your baby obstructed, present with high obstruction, means early bilious, early onset bilious vomiting, minimal abdominal distension, failure to pass meconium. First order is to perform X-ray, and then you decide according to the findings: single bubble, double bubble, triple bubble, few airfield. Then you put in your mind that your job here is to exclude catastrophic midgut volvulus. Order upper gastrointestinal contrast study. Normal position of the DJ, or there is corkscrew appearance, or there is complete duodenal obstructions or partial obstructions with normal DJ junction. Then if you find your neonate present with marked abdominal distension, late onset bilious vomiting, suspected that already gas is filling the midgut, so think of the distal obstruction. In such cases, the first order is contrast enema. To diagnose, we may find microcolon. This microcolon may be meconium ileus or distal ileal atresia, or short microcolon, diagnostic of the clonic atresia. Or you may find calibrate change in the colon, maybe Hirschsprung, maybe small colon syndrome. If you find normal contrast enema, in such a case, you must think again to perform upper contrast study. In all cases, malrotation and midgut volvulus must be excluded in all infants to avoid catastrophic midgut volvulus. Then you decide that your baby is transferred to surgery urgent or elective. So please put in your mind that your job in any baby with intestinal obstruction is to exclude the presence or coexisting or associated malrotation with midgut volvulus, whether the obstructions is proximal or distal obstructions. Your medico-legal aspect and your job and your important point as a pediatric surgeon is to exclude the presence of this catastrophic coexisting factor. Thank you very much for your attention. This lecture is very important to all pediatric surgeons. Please follow up and follow the systematic and pattern-based approach, and see you next subject of pediatric surgery made easy. Thank you very much.